Beautiful tone with a slow decay, gives everyone a chance to finish their paragraph. Welcome to the distinguished Levitt lecture. My name is Frank Degree, and I am the co-host of this event, along with John Samet, the Dean of the School of Public Health, who did me the great privilege of introducing me to our speaker today, which you'll soon find out why I'm in his debt for that. Louis Levitt was born in 1897 and became a family doc and a vet in the city of Denver, where he practiced for 40 years, retired in 1967. In 1977, when he died, he had bequeathed to us an endowment for the purpose of inviting distinguished speakers to this campus to inspire us and instruct us, edify us, and we've had over 50 speakers come under Dr. Levitt's aegis. Today is likely to be one of the best events yet, as you'll soon see. I would also like to welcome Sarah Miller and the students that she's streaming in to this event from Puerto Rico. We've got people from other places who are streaming this, so the invisible audience that I can't see with my eyes, welcome. And those of you who I can see with my eyes, I also welcome. I'd like to introduce to you Dr. Sandro Galea. I have a question for y'all in the audience. How many people here can speak Maltese? That's only one thing that our speaker is alone in being able to do here today. Sandro Galea is the Dean and the Robert A. Knox Professor at the Boston University School of Public Health. He's been the dean there for about 5 years, prior to which he was the chair of the Department of Epidemiology in Columbia School of Public Health. I could use his time telling you about how productive and how provocative and how thoughtful and how interesting he is, but I'm going to let him do that to himself. Let's suffice it to say that when Dean Samet was introducing him this morning, he held up the 3 books that Dr. Galea had written in 2019. And it goes like that. So just understand that you have before you today a public health professional who is exquisitely productive and thoughtful and is changing the field. He's going to talk with us today about an area that is, of course, of central interest to public health scholars and professionals, but it's also interesting to us in the world of primary care and in healthcare in general. As we try to think about population health and population health science, what better person to be here for us than Dr. Sandro Galea? And so without tooting his horn anymore, let me ask you to join me in welcoming Dr. Galea.
Good afternoon. Thank you for that super kind introduction. Thank you to Frank and John for inviting me. It's really a privilege to be here to speak on the occasion of the Levitt Lecture. And I'm going to dive right in, and I am going to talk about what I think there's a reasonable case to make are the 3 most important epidemics in driving U.S. health in the past decade to 2 decades. I would add to this list HIV sort of a decade earlier. HIV remains obviously a significant concern, but I think these 3 epidemics remain in a state of where we really haven't grappled with them in anywhere near the sophistication that we have with HIV. And what I'm going to do is I am going to weave in and out of talking about each of these epidemics. So I'm going to be going in and out of all 3 of them, assuming this is an audience that's sophisticated and knows a lot about this already and can work with me. But my fundamental point is that understanding population health science can give us a lens to understand complex epidemics, can give us a lens to do better causal thinking about complex epidemics, and ultimately can help point us towards solutions. And so I'm going to use the epidemics to illustrate the broader point about the centrality of population health science to all we do. So, without further ado, let me make the case for the epidemics. Let's start with opioids. Let's start with drug overdoses. So this is the drug overdose deaths. This is 3 years old now. Drug overdose deaths now are about 72,000 a year. The slide shows 64,000 a year. The key about the slide is to show that drug overdoses surpassed the peak of other previous epidemics, including HIV, which I mentioned, car crashes, which was in 1972, was the peak, and firearm homicides, which was in the early 90s. So while in the past 3-4 years we've heard a lot about drug overdoses, largely when deaths went over 50,000 deaths a year, we really should have been paying much more attention when deaths were over 40,000 a year. In the early aughts, I was studying drug overdoses, and I remember very clearly a well-meaning colleague from a large federal funder saying to me, really, there's no future in studying drug overdose because nobody cares about drug overdose. So this was really the overwhelming mentality not so long ago, but at that time, when that was the mentality, we still had 30,000, 40,000 people dying from drug overdose a year. And when you look at it this way, this is actually overdose deaths. The red is more overdose deaths across the country, going from left to right, from 99 all the way to 2015. You see sort of the hot spotting of drug overdoses. And my only ask to you all is, if you look at that, and if I didn't label that as overdose deaths and told you it was coronavirus as yet unspecified, how much would that freak you out? Right? Quite a bit. And we somehow have not seen this as the epidemic that is worthy of our attention as much as it is. And then one last point about this particular epidemic is that we actually are unique and an outlier. This is actually the case with all these epidemics I'm talking about among our peer countries. The red is us, percent of deaths that are drug-related. The other gray lines are other high-income countries. And you see that we are well ahead of other countries in number of deaths due to drug overdose. So that's making the case for the importance of that particular epidemic. Now let me make a case for the firearm epidemic. So we have had a firearm epidemic that has been roughly consistent for the past 20 years. So before the turn of the century, firearm deaths were higher in the US. That's sort of in the mid-80s to the 90s. That was largely due to cocaine, the cocaine epidemic. Once that went away, we actually got to a level of about 35, 36, 37,000 deaths a year from guns every year for the past 20 years. There's been an increase in the past 3 years, which you see over here as a tail, but ultimately, guns and their consequences have been at epidemic levels for at least 20 years, if not longer. And of course, this distinguishes us poorly compared to other high-income countries. This is only homicides. I'm not even including suicides here. But you see how off the charts we are compared to other high-income countries, making this another epidemic of real consequence in the country. And then the third epidemic I want to talk about is obesity. And you've all seen these slides, so I'm not going to spend much time on them, but this is just to remind us, this is from BRFSS data, which shows the darker the color is obesity per state. And really all I want to show here is that 1990, it's not that long ago, 30 years ago, right? The BRFSS data map went as high as 10 to 15% prevalence per state. By 2000, we now added the 20-25% category. By 2010, we had added the 30% category. And by 2020, which data will be coming out soon, we'll have a 35% category. So this is, again, an extraordinarily galloping epidemic of obesity. And guns, opioids, and obesity have contributed vastly disproportionately to our overall national health. This is my favorite gloomy slide about American health, and particularly I like it because it's of the title, American Exceptionalism. But all this shows is that until the late 80s, the US was gaining on life expectancy compared to our peer countries, that's the blue, but then you see in the mid-90s, we went into the red. So we actually started losing on health compared to our peer countries. And I could show you, I could spend the next 20 minutes, which I will not do, showing about how our health has been poorly served by a number of factors, but in particular by the forces that I'm talking about here, by the consequences of obesity, consequence of firearms, consequence of the opioid epidemic, with the added addition, the other thing that's affecting our health and is the consequence of aging. This is from a paper that came out recently in JAMA, and what this shows is the bar on the right shows where we are gaining in life expectancy. The bars on the left is where we're losing in life expectancy. And if you look at the bars on the left, you'll see that we're losing life expectancy in unintentional injury. Those are firearms. Alzheimer's, as I said, which is disease of aging. Suicide, which is firearms. Drug poisoning, opioid-involved poisoning. So essentially it is opioids, things related to guns, and disease related to aging. Let me move on to, okay, so why talk about them at the same time? Yes, they all matter, but I actually think that there are many things that these epidemics have in common. And just to summarize it all in one slide, they all matter, they all cost a lot of money, they all have complex etiologies, and they are all resistant to simple solutions. Certainly do not let anybody tell you that dealing with the opioid epidemic, the gun epidemic, the obesity epidemic is straightforward. So these are epidemics that are haunting our national health landscape, and that we, in the health enterprise and in the enterprise of the health of populations, have a responsibility to grapple with them and try to say, how can we best understand them to the end of introducing solutions? So what I want to argue is that thinking about population health science in a systematic way can contribute to our understanding about these epidemics. And of course, our understanding is to the end of informing interventions so we can do something about them. Now, when I say that, the first question is, so what is population health science? This is from this book that I had the privilege of writing with my colleague, Catherine Keyes. This was about 4 years ago now. And in it, we define population health science. We define population health science as the study of conditions that shape distributions of health within and across populations, and the mechanism through which these conditions become health. Now, that definition, probably familiar to many of you in some way or another, is fine, I think, but more importantly, we tried to nest the approach to population health science in some principles and try to say, what are principles that can help lead our thinking about population health science? And we articulate in the book 9 principles. These are the 9 principles. You don't have to read them all. And what we meant to do by articulating principles is 2 things. One is to provide intellectual scaffolding on which we can build approaches to understanding epidemics like this one. And secondly, to provide principles that are clear, that allow others to argue, to disagree, and to offer other better principles. And if you look at the book, we say very explicitly in it, this is our first go at principles, but we challenge the population health science community to come up with other principles. So this is a challenge to you all, as you're hearing me speak, both to think about what I'm getting wrong, what can do better, and to write your own papers that push our thinking forward. Now, what I want to do in the rest of my talk is I'm not going to talk about all these principles, but I'm going to talk about 4 of them. And I'm going to talk about each of these 4 and now weave in these epidemics, both to illustrate the principles and to illustrate what the principles can teach us about these epidemics. So let me start with the first principle. The first principle is population health is a continuum. Now, when we're writing this book, we argue about this principle because in some respects it's banal in its obviousness. And everybody hears it like, yes, that's fine. But I would actually argue, I would challenge you to think back about what I've said for the past 6 minutes. I've said obesity, opioids, firearms. And I would argue that in your mind, consciously or subconsciously, you have already been dichotomizing. You have been thinking about people who are obese or not obese. Those who are killed by a gun, not killed by a gun. Those who overdose from opioids or do not overdose from opioids. That mental architecture is dichotomizing, which is the opposite of thinking of population health as a continuum. Now, what does thinking of population health as a continuum mean, and what does it do for us? Well, let's start with obesity. Let's start with BMI. This is a population distribution of BMI. This is a classic population curve, which many of you, all of you who've read the Science of Preventive Medicine by Jeffrey Rose will have seen. And you see that most people in the population are a modal BMI, but of course we have certain people who are to the right of a cutoff, the cutoff being BMI of 30, definition of obesity, and those are the people who we refer to when we talk about obesity. Right? When I showed you the CDC BRFSS graphs, I was showing you the prevalence of the people to the right of the curve. What those graphs do not do, what in fact the biomedical approach does not do, is take into account anything to the left of the curve, which is the continuum of where weight is at. Now, why does that matter? Well, let's go back to the data and look at two curves. The dark line is national data from NHANES between 1976 and 1980. The dotted line is NHANES data 2005-2006. So I want you to see two things. Look at the right of the line. Right? The right of the BMI line shows there's more obesity in 2005 than there was in 1976 to 1980. No question there, right? That's the dichotomizing more obesity. But look to the left of the line. What do you see? You see that the whole curve has shifted. We now have many more people who are borderliners, who are close to being obese, because the nature of the curve has shifted in its entirety. That is the difference in thinking about health as a continuum versus thinking about health as a dichotomy. Now, you're thinking, okay, that's BMI, that's easy, I get it, BMI is a continuous number. But how about something like guns? We talk about guns, we know 36,000 people die from guns a year. Surely that is a dichotomy. But is it? Because the national conversation, insofar as the national conversation has changed on guns, and it has changed tremendously in the past few years, has been almost exclusively about people who die from guns. That, of course, elides a continuum of the consequences of guns. And that continuum looks like this. This is from a paper that we published. In terms of gun fatalities, they're only about 1/3 of the people who actually have a bullet go through their body in any given year. Another third are people who are injured severely, have to be admitted to hospital. Another third are relatively minor injuries. So if we are to think about guns and the consequence of guns, thinking about gun deaths, which by the way, again, is all I showed you when I made the case that this is an epidemic, and when you read in the public literature, the epidemic argument is made exclusively, essentially, on fatalities. It is hiding twice as many other gun-related injuries, half of which are serious enough to have hospital admission, and we know from other data that those hospital admissions are much more costly with much more morbidity than other traumas like things like motor vehicle accidents. And in fact, what really has been increasing and driving the epidemic of guns in this country is the non-fatal injuries. This is from a paper we published showing temporal trends in non-fatal injuries going up. And actually, this is another graph from the paper. Well, I want to show you the annual change per person. So if you look at the top bar, you see how homicide is going up, homicide attempts are going up. But look underneath it. It's not fatal homicide that's going up, it's non-fatal homicide that's going up. That is what's driving the change in morbidity from the firearm epidemic right now. It is non-fatal intentional injury. So even in guns, something that seems as intuitively dichotomizable as is guns, ultimately is a dichotomy sitting on a much more complex continuum picture. Now, how about, let me go back to fundamentals. Let me go back to obesity. A lot of our understanding of the science of obesity comes from dichotomizing. So when we think about things like cholesterol, which of course is a complicated picture, it ultimately comes from data that comes from the Framingham study, which is run by Boston University, where I am. And those data have allowed us to do things like Framingham risk equations, which has driven, of course, $1 billion of medical industrial complex that is all about cholesterol and lipids and all that. So just to make the point about the challenges between dichotomizing versus looking at things as continuous, let me show you the Framingham data from where we get the understanding that cholesterol is a risk factor for heart disease. Cholesterol is linked to obesity, risk factor for heart disease. Well, those data look like this. These are the Framingham data. The black line are people without heart disease. The dotted line are people with heart disease. Cholesterol is on the x-axis. What do you see when you look at both curves? They look almost exactly alike. Now, these are Framingham data. This is why we know about cholesterol. So where on earth does the Framingham risk equation come from? Well, it comes this way. We take this and we dichotomize. That's where it comes from. We dichotomize and we create a 2x2 table. And the 2x2 table gives us people who are exposed with disease, unexposed with disease, without disease, etc. And when you look at a 2x2 table, AD is bigger than BC, hence an odds ratio of more than 1, hence a risk factor. So we derive from a continuous distribution in a population a measure of relative association that rests on a dichotomy. There's nothing wrong with that. I want to be very clear that there's nothing wrong with that. But what it does is it hides the entire spectrum that goes underneath the dichotomy. And what it does is it embeds the fallacy that the risk factor at a particular level is going to be predictive of the individual with that particular outcome. Because of course, a relative risk measure tells us hardly anything at all about whether or not the individual with that risk factor is going to have disease. So let me ask you this question. You're all in an academic medical center. What relative risk measure do you need in order for a risk factor, documented like this, using a dichotomizing approach, to be predictive of whether or not someone with this risk factor has disease? Risk factor of 2, 4, 10, 20? How big does it have to be for the dichotomization to represent prediction of who's going to have disease? I'll let you come up with an answer in your own head, but the real answer is 350. And this is from a paper. This is on. I have a list of papers I wish I had written, but I did not. This is high up on that list. So you need an odds ratio of 350 to have curve separation that ultimately allows you to say that a risk factor is predictive of disease. I will not ask for a show of hands as to how many people in this room have actually participated in a paper with an odds ratio of 350. I have not. There are a couple. There's particular conditions under which you can have that, but I have not. So the bottom line is this, is that when we dichotomize, we are eliding the entire shape of the population distribution, number one. Number two, we are drawing inference about populations that obscure the relative disutility of inference from dichotomizing for the purposes of prediction. Because one needs an extraordinary risk measure from a dichotomized approach to actually give us prediction, which of course, when we're trying to deal with epidemics, prediction is a large part of what we're trying to do, because we are trying to identify and isolate who has the disease, illustrating the relative uselessness of dichotomizing for the purposes of dealing with epidemics like this. So principle one, these epidemics, like all the health of population, work as a continuum. Principle two, small changes in ubiquitous causes result in more substantial changes in healthy populations than big changes in rarer causes. Now, this is in some respects intuitive, but it's something that we forget all the time. And let me explain that by analogy. First of all, this is goldfish living in water. And the analogy I use is you want your goldfish to be healthy. So what do you do with your goldfish? You tell them to swim around their bowl 10 times clockwise, 10 times counterclockwise every day so they can exercise. And when you feed them those little flaky food, you tell them not to eat too much so they don't get sick. And when they do get sick, you get them the best possible goldfish doctor, right? And then one day your goldfish still die. So why do they die? Well, they die because you forgot to change their water. Now, does exercise matter? Absolutely. Does diet matter? Absolutely. Do doctors matter? Maybe. The water, which is ubiquitous, is ultimately the more important influence on our health. Now, you're all sitting there, I suspect, and you're all thinking, yeah, I know this is obvious. That's not so obvious. The way we do our business every day privileges the higher relative measure of association individual behavior over the context that is ubiquitous, that shapes the health of populations. Here's one concrete example. This is the crack cocaine epidemic of the mid-80s, which was linked to the availability of crack. You know, it's important because Tom Brokaw is talking about it. And this actually was the epidemic that launched 1,000 careers in substance use epidemiology, because there's a lot of money that was put into this. And of course, the crack baby epidemic, which was ostensibly about children born to mothers who used gestational cocaine, who then went on to have neurological symptoms, was a total bust, right? This is longitudinal studies showing this using the Peabody vocabulary test, that children of mother who used gestational cocaine, that's the gray line, versus mothers who did not use gestational cocaine, had absolutely no difference in their vocabulary over time. But there was something different about those children. And there was something that made enough for those compelling pictures on TV. Separate and apart from some early jitteriness, there was something deeper that was going on that was different about those children. What was different about those children was their context, that those kids were all born in poverty. They had no environmental stimulation, and it was that ultimately differentiated those children, not the higher risk short-term exposure to gestational cocaine. And that, of course, took us down essentially a wrong path for about a decade. And we do this all the time. I could actually talk about, for example, how we do this right now with our current day focus on ever more precise genetic and molecular targeting, but we can talk about that as a subject of another discussion. Now let me switch to the opioid epidemic. So what is ubiquitous in the context of the opioid epidemic? Well, what's ubiquitous in the context of the epidemic right now is the drugs that are driving the opioid epidemic, which are synthetic opioids. This is the rise in fentanyl, extraordinary rise in fentanyl that you see here, and showing that is ultimately what's driving the opioid epidemic. It is not, has not been for about a decade, prescribed opioids. It is illicit synthetic opioids that's been driving the opioid epidemic. That's the ubiquitous factor that is driving the opioid epidemic today, which means that from the perspective of, again, understanding the science to the end of doing something about it, that is what we should be thinking about. How about guns and the firearm epidemic? What is the ubiquitous factor in there? Well, the ubiquitous factor is guns, actually. So we have about 1 gun per person in this country, and in particular, we own about 4% of the guns, the handguns in the world, despite the fact, about half the handguns in the world, despite the fact we're only about 4% of the world's population. And we could spend a lot of time, I could do a whole hour talk, about the science of firearms and the firearm consequences, and as well as the ethics and the legalities of firearm consequences, but I'm just talking here from a population health perspective. Population health perspective, more guns result in more consequences of guns. Fewer guns result in fewer consequences of guns. And there are ample experiments that have shown this. This is Connecticut that passed a law adding background checks, resulting in a drop in homicide 40%, a drop in suicide 15%. Conversely, Missouri actually repealed license requirements, show an increase in homicide, increase in suicides. So the ubiquitous factor is the unfettered access to guns. And really no conversation about the firearm epidemic can be had without that being part of the conversation. How about the obesity epidemic? What's the ubiquitous factor there? I always like showing this slide over lunch. Because the ubiquitous factor there is calories. So this is calories of food 20 years ago versus today. So 20 years ago, you had a bagel for breakfast that was 140 calories. Today, it's 350 calories. It's still a bagel, right? You still had a bagel. God help you if you had a muffin, which used to be 210 calories. Now it's 500 calories. And I didn't actually look at what's in everybody's lunch, but if it was cheeseburgers, that's 600 calories versus 300 calories, and on and on and on. So we are but mere mortals. And, you know, I don't know about you, but It's not like 20 years ago I used to have a full bagel, now I have half a bagel. No. I had a bagel then, I have a bagel now. Only now, that's gone from 150 calories to now 350 calories. That is the ubiquitous factor that has changed and driven the obesity epidemic. And I'm saying this not to minimize the contribution of many, many other factors. I'm going to end on some of the complexity of some of these ideas. So please do not take from this that he said nothing else matters. No, what I'm talking about. I'm talking about the fact that a clarity of thought about the ubiquitous drivers of these epidemics can help us think about the interventions that can have most consequence. And we know that to reduce obesity, you need comprehensive programs. So we know that. And of course, that is because there's no simple way of dealing with the availability of the bagels and the muffins and the cheeseburgers, because those stay all around us. So once you understand ubiquity, you're still tied in a bit of a box as to what to do about them. So second principle, which ties these epidemics together, is the principle of ubiquity. Third principle, that is the one that's wordiest, which is the magnitude of effective exposure on disease depends on the prevalence of other factors that interact with that exposure. So what do I mean by that? I'm going to show you this by example. And let me ask this very simple question. Let's focus on obesity. How much of your obesity risk is due to your genes? So here's the question. Here's the assumption set. Let us assume that there are two things that matter for obesity. One is genes and one is environment. They both matter, okay? Genes and environment. And I'm using the word gene environment as a gross simplification. We understand it's probably multi-genetic, and environment is many, many forces, including the ubiquity of sort of high-calorie bagels. So I'm telling you, both matter. My question is, what percent of the risk is due to genes? Now, what I would like everybody to do is answer the question. And assume it's a test, and I'm going to get you to write it down. You don't have to write it down, but you have to be honest, okay? So you have a booklet in front of you, and the examiner's question is, assuming that both genes and environment matter to obesity, and they both matter jointly, comma, what is the percent of the risk that is due to your genes? Write down your answer, and then we're going to compare it. Does everybody have an answer? Okay? All right, so let's do the math. Let's take a population. This is a population of gray people. My schema is as follows. The black is genes, so you have the obesogenic gene, whatever it is, again, assuming that there's one gene, okay? And the green is obesogenic environment, whatever that is, whatever complex. It's a high bagel environment, doesn't matter. It's the environment that causes obesity, okay? We're simplifying, that's part of our assumption. Genes and obesity both matter, and they matter jointly. So they matter, and black plus green is going to become obese. So black plus green becomes red. So I'm showing obesity as red, okay? I'm also throwing a few random red people here because we all know that life is complicated and there are some people who are going to be obese despite not having the gene or the environment. So I'm throwing a few random red people. So let's do the math. Let's take this scenario. Here's the scenario. The black genes, they haven't moved. That's exactly what I showed you before. I'm making them as dots so you can see it behind the green, okay? So I've put everybody in an obesogenic environment. It's nearly everybody's in green. You see that? There are some random red people, but what I'm doing here, the black, which is the obesogenic gene, plus green becomes red. So now you can do the math and say, what's the relative risk of obesity given the gene? Well, everybody with the gene has essentially become obese, right? So you do the math here, relative risk becomes 4, but the PARP, which is a population attributable risk proportion, is 100%. Because everybody with the gene became obese. So from this scenario, the answer to the question, what percent of our risk of obesity is due to our genes, the answer is 100%. But wait, not so fast if you said 100%. Let's do a simple second scenario. Same gene pattern, you see the same black pattern, same random red, but now the obesogenic environment is only on the right. Notice how now only 2 people with the black, which is the obesogenic gene, are now in an obesogenic environment. Only those 2 become red. You can do the math. Relative risk is now 1.7, the PARP is 40%. So what's the answer to the question? Under the assumption that genes and obesity both matter, and they matter jointly, the percent of the risk of obesity due to genes is, I cannot tell you unless you tell me about the other factor. Now be honest. Raise your hand. How many of you wrote that answer in your exam book? How many? Now, I've used that example a few dozen times, and I promise every time I do it, I also come up with an answer in my own head because I can't help myself. Because we are so accustomed to thinking that we can control for other stuff and come up with a simple answer. Now, I didn't mislead you, right? Do you all notice that there were 3 times when I told you what the assumptions were? I was very transparent what the assumptions were. But our brains are accustomed to this thing. Yeah, I know there's assumptions. Yeah, I know there's other stuff. But you're asking me what percent, so I'm going to give you a percent. The answer is you cannot give a percent because these factors operate together. So under the very plausible assumption of co-occurring causes, the gene obesity association can only be understood if we understand other factors. Sorry, it says urban factors. I was doing a book on urban. Other factors that create the conditions for disease. And that is fundamental to how we understand the determinants of health. And we miss this all the time. And there is a real consequence to missing this, because we publish paper after paper that say blueberries bad, no, blueberries good, chocolate bad, chocolate good. There's nothing wrong with all of those studies. They're all fine, they're all internally valid, they're all done by very smart people. But they are missing the co-occurring factors, and we are confusing everybody. So this becomes a core driver of how to understand the health of populations. By the way, this is not theoretical. I know you probably know I'm an epidemiologist, so epidemiologists, they use flim-flammery. It's not theoretical at all. When you look carefully at the science of obesity. This science of obesity, this looks at physical activity, and what you're looking at is BMI and physical activity by genotype. And you see classic effect modification by the genotype effect on BMI by physical activity. So we know this. Let me go back to the Framingham data. I want to show you the Framingham data that I showed you earlier, and now I want to show you genes and diabetes. So let's talk about genotype and diabetes. Here's genotype score and risk of diabetes. This is from the Framingham data. So what you see here is the higher the genotype score, the higher the cumulative incidence of diabetes. Now, what question crosses your mind when you look at these data? I know when I look at these data, the question crosses my mind is, I wonder what my genotype score is and whether or not I'm going to get diabetes. It's like we can't help ourselves, right? But the reason I love this paper is because while showing us genotype score and incidence of diabetes, it also shows this, which is genotype score and the population curve of who has diabetes and who doesn't have diabetes. And what you see, of course, is that the two curves are nearly overlapping. This phenomenon, which is the difference between a population-based perspective and an individual perspective, namely the population level, the genotype score might be discriminative. At the individual level, it's not discriminative at all, is simply due to one thing and one thing alone, which is the presence of co-occurring factors. So unless you're willing to believe that there is a single genetic variant that is driving any of these epidemics we're talking about or any other population health outcome that exists independent of other factors, and by the way, that is the case for in some cases in rare diseases. For example, some types of cystic fibrosis, right? But that's not how genes work in the rest of the health of populations. We cannot understand the genes without understanding the other co-occurring factors. Similarly, we cannot understand the other co-occurring factors without also understanding genes. So it's not an anti-gene argument, it's an anti-absurd reductionism argument, and says that we need to understand the full set of factors that ultimately drive the health of populations. Let me come to another epidemic. Let's go back to opioids now. So what are co-occurring factors driving the opioid epidemics? Well, there are several. Here's one of them, which is people receiving substance use treatment. I mentioned the ubiquitous factor being availability of opioids, but substance use treatment, or lack thereof, which is available to a very small minority of people who actually need it. And then, of course, another co-occurring factor is the public conversation about opioids, namely the people who perceive a need for treatment. Only 5% of people who could benefit from substance use treatment perceive that they have a risk of treatment. Like, that is an extraordinary co-occurring factor that ultimately determines the extent to which people seek treatment or do not seek treatment. So principle 3, or the third principle I'm talking about today, is the importance of understanding co-occurring factors. Fourth principle. And this is, I left this for the end because this is the one that sort of makes us most uncomfortable. When we're dealing with improving population health, and I started at the beginning by saying, look, opioids epidemic bad, obesity has consequences bad, firearms has consequences bad, right? That's where I started. Implicit in everything I said was, we should be doing what we can to make bad less bad. But we keep eliding this concept that it's not so clear sometimes that what we need to do is to drop sort of disease versus widen health gaps. And efficiency in improving population health is frequently at odds, if not always at odds, with the goals of narrowing health gaps. And let me show you what I mean by that. Let me show you with a couple of illustrative examples. Let's say you have a population up top with a population which has 50 DALYs, another population which has 25 DALYs, disability adjusted life years. Okay? And if we intervene in a way that we're adding 1 DALY per 50, look at the second row. You've gone from 50 to 25 to 51 and 25.5. Now you've widened the gap. Let's say you add 10. You're adding 10 to the 50, you're adding 5 to the 25. You're now gone to 60-30. So you've increased your overall, and you've also widened your health gap. And this is also true if there are no health gaps to begin with. Before intervention, you have 50 and 50. You do intervention, high SES, low SES, you end up with 60 and 55, with an inequality of 5. Now, this is just illustrative examples, but let's just take it to real life. Let's take it to real life. You are responsible for a community. You're responsible for a community. This is a great Department of Family Medicine, School of Public Health. As I've heard today, you're doing some outstanding work in terms of improving the health of the population. Now, if you were to tell me, let's take a community and improve its health. I don't know. Let's say you want to improve its colon cancer mortality. Say, what are you going to do for that? Well, let's improve screening. And if you put me in charge of improving screening for 100 people, what am I going to do to improve screening? Well, I'm probably going to think of some way to have messaging that penetrates, and that messaging is almost certainly going to penetrate much more in the top group than it is to the bottom group. And I'm probably going to be able to achieve higher screening, lower colon cancer mortality at the expense of widening health gaps. The question is that okay? And the answer is, I don't know. But we should certainly be honest about it, and we should certainly discuss it. And this phenomenon is almost always the case. Now, I could sort of go back to the epidemics we're talking about. Let's talk about firearms. This is the extraordinary outcry led by Parkland High School students, and has focused a lot of attention on firearms without really focusing attention on this. This is fatal firearms by race, right? Twice as many blacks as whites as Latinx people are injured by guns every year. And we talk about mass shootings account for less than 2% of annual gun deaths. And the one thing we never talk about mass shootings is predominantly a black school phenomenon. It is black kids make up 16% of the school population, and they experience twice the rate of mass shootings. How many of you knew that? Right? It is something obvious that we should all know. So our thinking needs to be informed by a concern with improving population health and by narrowing health gaps. But efforts to improve population health not infrequently run up against the narrowing health gaps goal. And I think we in population health have a responsibility to grapple with this question and to say, how much efficiency are we willing to trade off for the sake of equity? And conversely, how much is equity worth it to us? Now, if I were to ask you to raise your hand, which I won't, to say, how many of you walking into this room, if asked, would have said, health equity is a core part of the job of public health? You would all raise your hand, right? It's part of how we think. How many of you walking into this room were willing to say, yeah, but I'm willing to trade some equity for efficiency? You're all laughing. I don't know. Are you willing to trade? I don't know. I actually don't know. I'm simply saying that we should be having this conversation. In some respects, this is so fundamental to what we do. The fact that we do not have this conversation, I think to my mind, shows an enormous blind spot. Now, why do we not have this conversation? It's not because we're not smart. I like to think we're pretty smart. It's actually because we haven't organized our thinking in such a way as to understand the fundamental principles that explain population health, to be able to surface these tensions. So what I've been trying to do here with thinking about population health science instead of principles is to surface these questions to force us to confront them. So let me conclude. Let me come back to 3 epidemics. So I talked about 3 epidemics, talked about obesity, I talked about firearms, talked about opioids. And these epidemics have a lot of things in common. I said at the beginning that they're costly and they're complicated. They also have in common a lot of forces, a lot of factors that suggest particular methodological approaches. People interact with one another in these epidemics. There's feedback, individuals interact with their environment. They're non-linear, they're dependent on history. There are trade-offs to be made in improving one thing and sacrificing another. There are causes and effects separated by time and space. You do X and it takes years for the consequence of X to happen. And when you in your classes do structured thinking about these epidemics, you come up with frameworks like this. This is the foresight model about obesity, and which talks about sort of the psychology, dietary habits, appetite control, physical activity, all of which controls obesity. And that is very good. There's nothing wrong with that. And that is the middle of that. That is the full foresight model of the determinants of obesity. And there's nothing wrong with that. I actually put this up admiringly. But I'm putting it up to remind us that we are dealing with immensely complex phenomena, and these forces, these characteristics I talk about, are in fact characteristics of complex population systems. And we need to be aware of the fact that we are dealing with epidemics that arise out of complex population systems, which makes suggestions about the kind of methodological approaches we use, and which, to my mind, argues then strongly for a doubling down on developing a science of population health that has the confidence and the nuance to think about epidemics like this and to articulate the principles and use the methods that are necessary to understand these approaches. Unfortunately, we, because we're a pragmatic discipline, I'm using the term we here to refer to those of us in population health and in the practice of public health, our entire foundational mythology is on silver bullet approaches. This is Jon Snow, which is, you cannot walk into a public health building without saying Jon Snow, because we love this story, right? It's a great story. He does a map, cool, we all like maps. We do, we all like maps. And then there was a pump handle, and he removed the pump handle, and voila, problem solved. What we never talk about is this. That's the epidemic curve in Jon Snow's time. That's when the pump was closed. Now, I don't know how many of you are infectious disease epidemiologists, but for the rest of you, it's not that hard to figure out the difference that the pump handle actually made, which is next to nothing at all. Now, don't get me wrong. The Jon Snow effort was very important. It was very important in terms of setting precedent, in terms of its extraordinary deductive capacity about the role of transmissible bacteria at a time when actually these things could not be seen. But the message we take from the story is often wrong. We take the message that we can come up with simple solutions, and there are no simple solutions. And our quest for simple solutions results in this. This is our spending on health in this country and our life expectancy. On the x-axis you have spending, on the y-axis you have life expectancy. You see all the rational countries in the world go up, right? You spend more, you get more health. And us, we're like children who are failing to thrive, right? We're like falling off the curve. We spend more and more money, and our health is ever worse. And the reason for that is because we're looking in all the wrong places. We are committing the worst form of lamppost bias, looking for the keys under the light, because that's where the light is, but that's not where the keys are, because it's not where we lost them. It's just we lost them in the dark. And that is lamppost bias, and it is informed by the fact that we're looking in the wrong places. And my hope is that population health science can help us actually understand better to the end of improving health. I'll end with one story, and then I'm happy to take questions and challenges. This is a story from my latest book, which is a story of Blind Willie Johnson, who was a blues man. And Blind Willie Johnson was born in Texas at the turn of the 20th century. He was born sighted. He lost his vision at age 7 when his mother threw lye in his face in a domestic violence incident. So he grew up poor, blind, black in Texas in the beginning of the 20th century, not an easy living, as you can imagine. He got married. Him and his house were living in a small house which burned down, and they didn't have any money. So they kept, actually, when the fire died down, they actually went back and lived in the charred remains of the house for their adult life. When he was in his early 40s, Blind Willie Johnson got malaria. So this is Texas in the 1940s. Malaria was not uncommon at the time, it's not particularly uncommon. His wife took him to hospital, and he was turned away from hospital. It's not clear if he was turned away because he was poor, because he was blind, or because he was black. And Blind Willie Johnson died. And the question I use with audiences is, well, what killed Blind Willie Johnson? Well, what killed him was malaria, right? Malaria killed him. Had he had treatment for his malaria, he would have lived. But the reason I tell this story is because it's obvious to everybody listening. It's not just malaria that killed him. It was racism, it was poor access to care, it was homelessness, it was domestic violence. It's all these forces that killed him. Which gets me then to the complexity of health and populations. That is what population health science is about. It's about understanding all these forces and how they contribute to the generation of health and how contribute to the generation of healthy people and healthy worlds. And that is a big task. It's a big, important task, which is why I would argue that we would do well to organize our thinking and to think about the science of population health, to think about principles and approaches that can bring together complex problems to the end of identifying what the causes are and what we can do about them. That's it. I'll stop there. Thank you very much for having me.